Between 1999 and 2019, nearly 841,000 people died from a drug overdose, according to the Centers for Disease Control and Prevention. In 2020, the addiction crisis only got worse as the country grappled with COVID, and many patients paused medical and mental health treatment. As a consequence, overdose deaths spiraled, with more than 101,000 Americans losing their lives from a drug overdose between April 2020 and April 2021. Today, with resources back open, more people are finding help, but substance abuse is still not under control. Overdose deaths from opioids like heroin, fentanyl, and prescription opioids have increased over 6 times since 1999. There's no doubt that addiction is a public health crisis. With billions being spent on addiction research and treatments, what are clinics focusing on to better help patients? To better understand the current crisis, it's important to go back to the beginnings of the opioid epidemic in the early 90s.
There was a very large sort of general encouragement for the prescription of pain medications for anyone coming in with pain, opioid medications. And pain was considered something that you should be attending to. Physicians were encouraged to ask it as almost the symptom that was never asked enough, and to pay attention to it and to prescribe opioids more freely and with less monitoring than actually these compounds deserve.
That's Dr. Anna Rose Childress, a research professor in the Department of Psychiatry at the University of Pennsylvania Perelman School of Medicine. She's also the director of the Brain Behavioral Vulnerabilities Division within the Center for Studies on Addiction at the university. Childress says that this period in the 90s of overprescription was heavily driven by pharmaceutical companies looking to expand the drug's use and increase profits.
They were very happy to have them used very broadly, not just for acute pain, where they're very, very welcome, for some kinds of acute pain, burn pain, things that are very acute, very useful, but their utility for longer chronic pain is really not there. But in fact, the companies were really encouraging clinicians to use these medications, not just for terminal cancer pain, which could be prolonged, not just for acute pain, but for other kinds of pain disorders, many kinds, everything from back pain to different sorts of complaints that people would have. They would end up having opioids prescribed.
And many times after people began using these prescription opioids, they were soon hooked and needed a larger dose to get the same effects.
Basically, people who began to use these things initially as prescription pain medications, they were very expensive, and it was harder and harder to get the doses that people had been prescribed, and therefore wanted larger doses, because with opioids, one of the really common things is that you get rapid tolerance, meaning that the same dose of the drug will no longer produce the same effect. And so what would happen is that people who could no longer afford access to these pills, even from places that were prescribing them liberally, they would switch to injected heroin. So what we'll call the third wave is this sort of surge in transition from people who started out as prescription opioid users, but then now transitioned to heroin. So that increased the number of heroin users in the country, which has always been there, but it boosted those numbers.
On top of this, in the last few years, the more potent synthetic opioid fentanyl has also seeped into the U.S. market. Childress says it's so deadly because the drug is cheap and just a few grains can end in an overdose. Fentanyl has spread so quickly that now in several regions of the U.S., it's replacing heroin.
Basically now in Philadelphia, if you look at the urines when people come in or the overdoses at the medical examiner's office, fentanyl has basically replaced heroin. So we now have, I'll call it the fentanyl epidemic.
Childress says that in some cases, EMTs responding to drug overdoses administer more than one Narcan dose to revive users, but this doesn't always work.
It's so potent that just one dose of Narcan, naloxone, which is used to reverse a regular old overdose, may not be enough to keep the overdose reversed for very long. It may bring the person back for a few minutes or a little longer, but they may then again lapse into respiratory depression. So one of the big needs for the field is to have multiple doses, or preferably, hopefully, something that's eventually powerful enough as an overdose reverser to work even in the presence of fentanyl, because that's a very active area of research at this point.
Aside from using Narcan for an immediate treatment to an overdose, medications like methadone and Suboxone are approved by the Food and Drug Administration to help treat opioid use disorder. When continually taken as prescribed, Childress says these can help to lessen the effects of physical dependency on opioids and help patients struggling with addiction lead a more normal life.
Both methadone and buprenorphine/naloxone, extremely important tools. And importantly, there are treatment slots that are open, available for people in our city and other cities that basically, could be taken advantage of, but are not necessarily. What are people looking for beyond these? Everyone, the research field is looking for always the non-addicting analgesic medication, right? So that we don't get into the problem that we got into in the 90s when people were being so encouraged to prescribe and prescribe and prescribe.
Finding a pain medication that taps into opioid receptors in the body, lessening pain, but does not have any addictive properties is a tough ask. However, researchers are making some progress.
There are already things that are looking pretty good in the preclinical animal models for being able to separate out effects that you want, which is an analgesic. We all need painkillers. We need pain medications. It's the humane thing to do, but that won't bring with them the risk of overuse and addiction. We also have research ongoing and trying to look for things that will be helpful for relapse, for example, for stimulants. We don't have any FDA-approved medications for cocaine or for methamphetamine or for cannabis. So though we have a handful of medications for alcohol, a handful of medications for smoking and for opioid use disorder, we don't have any for stimulants or cannabis. I think people thought it would be easier than it has been, but what we do have are some promising indications.
And these developments are targeting categories of medications that can be used in a wide spectrum of patients that are past withdrawal, but still at risk of relapsing. Childress says this approach is especially useful because it's very common for people suffering with addiction to use more than one substance.
Withdrawal is very annoying, and it certainly could drive someone back to relapse, but a lot of return to drug use occurs long after the last dose of the medication and long after any withdrawal. It occurs when people see things, think about things, encounter things, remember things, even wake from a dream that reminds them of their preferred drug. And it sort of kicks into action this sort of ancient reward circuitry that sort of says, I think I know what I would like, and I think I'd like to go get it now. And that state is probably something that's shared in common across drug classes, whether you're looking for the cigarette or the dose of opioid or the dose of stimulants. So we're looking in our lab and others for medications that might be able to modulate that state, that might be able to bring that I want it now, I've got to have it now state into sort of a more manageable range. And that's an exciting thing. And there's several classes of medications from preclinical studies and moving now into clinical work that show promise in that regard.
Dealing with addiction is different for everyone. What may work for one person in treatment might not work for another. Childress says that along with prescription solutions, equally important is access to a therapy-based treatment and emotionally supportive network that supports the patient. While some may go through treatment once and feel like they're no longer at risk, this is not the norm. Generally speaking, many people relapse, and recovery can be a years or decades-long struggle. Yet Childress says it's important for people to not define themselves by their addiction.
I think it was in treatment communities where people were trying to keep people aware of their vulnerability, but in trying to do that, I think the unfortunate thing was that the labels got used in a way that felt like it was deterministic, like no matter what I do, this is what I am and this is all I am.
If you or someone you know is struggling with substance abuse, find help and resources at samhsa.gov. That's SAMHSA.gov. There's also a National Substance Abuse Hotline at 1-800-662-4357. The helpline is free, confidential, and open 24 hours a day, 365 days a year. To find out more about our guest, Dr. Anna Rose Childress, visit viewpointsradio.org. For more behind the scenes, search Viewpoints Radio on Twitter and Facebook. This segment was written and produced by Amira Zaveri. I'm Gary Price. Coming up on Viewpoints.
The families that I spoke to, every single one of them, their main priority was first the safety of their children, getting them to a safe space.
The refugee crisis in and around Ukraine, as well as across the globe. Then,
they're not designed to last. They're designed to realize a profit very quickly.
Understanding the declining quality of the clothes we buy. I'm Marty Peterson.
And I'm Gary Price. These stories in depth on your public affairs magazine, Viewpoints.
And that's Viewpoints for this week. Follow us on Twitter, Facebook, and Instagram to learn more about upcoming shows and find a library of past programs on Apple Podcasts, Google Play, and Spotify. Plus, you'll always find previous segments and more information about our guests at viewpointsradio.org. Join us again next week for another edition of Viewpoints.